it's me, Jen again, and today we're meeting an interventional radiologist with a passion for thyroid health. We'll be joined by Dr. Pranav Shah coming up. As an interventional radiologist, Dr. Shah has had a daily relationship with ultrasound imaging and interventional procedures throughout his career. But his passion for the thyroid led him to develop a thyroid-specific practice, a rare specialty in this field. As a result, he has found Thyroid RFA to be a natural addition to his practice. Today, we'll be learning more about Dr. Shah's passion for Thyroid RFA, as well as his very unique practice in Red Bank, New Jersey. It is a pleasure to meet you today, Dr. Shah.
Thank you.
I've heard that you are quite passionate about the topic of RFA.
Yeah, RFA and actually all thyroid stuff. I started out many years ago, actually more than 20 years ago. I finished my residency in 98 and did my fellowship in interventional radiology in 99. Then I've been working ever since, so 22 years. And for most of that time, it's been interventional radiology. During that career, which involved all manner of invasive procedures and things like that, we developed this thyroid following. The skill set of interventional radiology is very applicable to the field of thyroid intervention, because we use ultrasound guidance to do our procedural work, and we do that in interventional all day long on the body part. So we became really good at doing it in the thyroid, and so developed this big thyroid practice. And eventually I decided to just branch out on my own and left interventional just to do thyroid work, basically head and neck work.
Wow.
Which is unusual. There aren't too many people doing just that. Been at it since February 2018. It's nearly fully dedicated to thyroid work, thyroid biopsies, complicated thyroid ultrasounds, post-thyroidectomy ultrasounds, post-radiation ultrasound. We do all the whole suite of complicated neck cases. And along comes RFA, which is a tremendous opportunity for patients. I'm very enchanted with it. So I picked it up right away. Got myself the training in it, and the skill set was very applicable, so I had no problems starting to do the procedure. And we did our first case. I think we have 3 more cases lined up now the next few months. So I'm very excited about it. First lady did very well. She was over the moon about it. I'm so excited for her. No, really, it really is a life changer for a lot of people.
Oh, absolutely. It was a life changer for me, which is why I'm here talking with you today.
So you underwent RFA, right? What is your story?
Did.
Tell me your story and how you wound up, going that route.
Sure. I had a thyroid nodule diagnosed in 2014. It was really not bothering me, and I'm interested in having surgery because I have a very complicated past when it comes to some bad surgeries, and very, very bad situation with a systemic staph infection that almost killed me. And I was advised to never have surgery unless I was dying, any sort of surgery. So when I lived with this nodule for several years, it didn't really bother me. But in 2018, I started noticing I was just tired all of the time, didn't really feel quite right. And by spring of 2019, I was like, okay, I've got to find out why I'm feeling so rough. And I went to the doctor. All of my lab work was normal, but I had this mass, this thyroid multinodular goiter had grown into one mass on my right lobe.
You see it all the time.
Big.
You see it all the time.
Yeah, it was huge. It was overtaking the entire right lobe. The doctor says, oh, you need to have surgery. And I'm like, can't have surgery. That was in February. Well, by May, random urinary tract infection, took a round of antibiotics, and I had an allergic reaction. And when that allergic reaction happened, my nodule, well, it almost doubled, around 45 milliliters up to somewhere between 65 and 75 milliliters.
That's
it was very uncomfortable. It was to the point that I would feel lightheaded if I turned my head.
My God.
I had very difficult swallowing, difficult breathing. I couldn't lie down to go to sleep. And I was in a panic all the time from that feeling of just choking. And I couldn't live with it anymore. And I thought, okay, I may actually have to have surgery, but I was really desperate not to. And so I just did a lot of reading and a lot of researching. And I came across RFA one night at 2 in the morning, when I couldn't sleep. And I ended up going to, my doctor's actually an interventional radiologist too, which is, as you said, very uncommon in the
Yes.
field of RFA. Most of
Yes.
endocrinologists and ENTs.
Yes.
But my doctor is an interventional radiologist. I traveled from North Alabama to Virginia to have my procedure.
Wow.
It was worth it, absolutely worth it. I had that done in July of 2019. And I had to have 2 procedures because part of my nodule was below the collarbone. It was low to access.
Right.
So about 9 months later, in March of 2020, I had a second round. And since then, my nodule has decreased 90%. So
That's fantastic.
life-changing, to say the least.
That is such a great story. I mean, you should be telling the entire world. I'd be willing to bet there are so many people with parallel stories that have a similar issue as you, which we see in our own patients, and they don't have a clue that there are other options besides surgery. They just don't know. It's not very well publicized yet. So I'm trying. No. In fact, this week I'm supposed to meet with a social media expert to be able to take my practice, which is online, and it's in the cloud. It's a very up-to-date practice, but it doesn't have all the components of social media hooked into it. It's the only way I'm going to get the word out is to leverage social media. There's no other way. You can't do it patient to patient. So I'm going to have to hire somebody to rework the logistics of the practice on the web to be able to harness all of those things, and hope to get people who are able to travel. We have people from right now that I get that are not necessarily RFA patients that come to me for thyroid evaluation and biopsies. We could do complicated biopsies from as far down as Maryland. I've had people from west of Philadelphia. I've had people from upstate New York, and people as far down as Maryland come to me. Just people actually, some of them used to live here and moved and still come back here for their medical care. So it means a lot. I mean, that means everything to us as doctors, to have people trust us to come back for such long distances to do their work on them. So I hope to be able to spread the word of RFA in Central Jersey. Right now, there's nobody here in Jersey doing it. I'm the only one.
Yes, I can't tell you how many patients in our Facebook group have been asking, is there anyone in New Jersey? And at one point in time, we did think that there was someone, but it turned out that it was wrong, or maybe they hadn't started, or they were thinking about it, but they decided not. I can't recall. But bottom line is, there are patients in and around New Jersey who are looking for this. There are patients all over the world who are looking for this. Our Facebook group is up to 2,700 members.
Oh my God,
and
that's amazing.
Patients all over the globe, and they want this. They're so desperate to keep their thyroid intact, to not be dependent on a lifetime of medication, to not have to worry about surgical complications, or maybe they're like me and they can't have surgery, whatever it is, they want to keep their thyroid intact and avoid surgery. And so I can see, as you said, social media is the key to getting the word out. Everyone's on Instagram these days scrolling. And if you want to get in front of people, that's going to be the best way to do it, is through social media.
Well,
Instagram is a big one right now.
You look very young. My daughters are probably around this. Well, I think you're like 25, 26, right in that age. I don't know how old you are, but you look very young. So
well, I appreciate that. I'm 38. I'm almost 39.
You look like you're 25, so that's great. It's a great start. So my oldest is 26, and she is, and of course, my 26 and my 24-year-old are very adept at all the social media. They're on every platform you could possibly imagine. I'm on none, zero. I don't even have a Facebook page of anything. My wife is on one. So they're always hounding me, Papa, you've got to come into the 21st century. Your practice is so, the reason is, I think that they're correct and you're correct, is our practice is niche. It's not a cookbook practice where you could just, it's not a commodity. It's a very specialized practice for special people. And so how do you reach those special people in any meaningful way if they don't live within a 5-mile radius of you? There's no other way. So I'm going to do this. I'm going to definitely get onto that bandwagon and try to get our practice and our philosophy out into the world so that people who are within a reasonable range of coming here can actually benefit from it. And we have a beautiful little office setting. There's, our staff is very patient-centric. It's such a nice place to have something done. It's not a hospital. There's no big registration process. There's no, going down escalators and other nothing. You just walk in and you walk out. It's very convenient. And that's really the way it should be, these type of procedures. They should not be hospital centric anymore. Hospital is a very tough place for patients, It brings up a lot of anxiety.
Yes, it's wonderful. I did mine at a hospital because that's where my doctor's located, but I believe most patients prefer the option of not going to the hospital, especially right now during COVID.
Yes.
People prefer the option of being able to avoid a surgery, which is going to be in a hospital setting, and being able to just do this outpatient. And, you were talking about how patients in the general area of New Jersey, hopefully that you could be reaching out to them through social media. But I will tell you that patients will travel quite a distance to get a doctor that they feel is really skilled in this area. Given that you have such a great deal of experience specifically in interventional radiology and in the thyroid, I believe you're probably going to see patients coming from much further away than you're currently already seeing once you get the word out about your practice. It's like with my YouTube channel, and my Facebook group, I never in my wildest dreams would have imagined that I would have people contacting me from the other side of the globe on a regular basis. I get messages all the time from people in Indonesia. I've had a few from India, China. Indonesia is a big one. The Philippines. The Philippines doesn't have anyone offering RFA.
Really?
And the Philippines is probably where I get the majority of my overseas messages from. And I'm just like, okay, somebody in the Philippines, pick this up, because it's in Japan, it's in Korea, it's in India.
Yes.
So there's demand for this. And I believe that even though it is such a small niche, and I understand, because it's the same for me, as far as with my YouTube channel, I know I'm not going to have viral content, right? I'm not going to be getting millions of subscribers, but to the people, as you said, that it matters to, yes, it's everything. Because they want to know about this and learn about this.
Yes. No, I really admire what you've done with it. I saw your story. I mean, it really is heartwarming, because without social media, and let's go back 10 years even, before social media was really ingrained in the general workings of people's everyday lives, the only way to really communicate or even know that you had another person in the other side of the world who shared the same concerns and anxieties as you would be to read about it in the paper. Or to read about it in a magazine. Somebody got profiled, and now you read it in Time magazine, or you read it in some magazine, and you find out there's somebody on the other side of the world like you. But they're all out there. It's not like they aren't there. They're there. We just have never been able to network them into the same intellectual space. And so your YouTube and your other modes of reaching out through social media are an incredible opportunity, because that's what it does. It creates an intellectual thought group. People who think like other people who think like themselves tend to draw to each other. So this niche problem of thyroid issues is really a community, which I'm finding out now. And because quite frankly, thyroid disease is not really that well understood, even though we do lots of procedures and we do lots of biopsies, and now we're doing RFAs. Really, in the world of science, thyroidology is not a very well understood science. As counterintuitive as it sounds, there's still way more to be learned. We just don't know enough, even just the functionality of the thyroid hormones, what it does. We're just starting to learn. It's fascinating, isn't it? I find it mind-boggling after all these years to know that we really don't know that much. Fascinating. So to have this group of people who are like-minded, all working towards the same goal, it's really cool. I'm very excited about it. I hope to get patients from wherever and talk to them and help them out in any way that I can. Let's see what happens.
For the viewers who might not understand exactly what an interventional radiologist is, maybe they've heard of a radiologist, but don't understand what interventional means. Could you give a little explanation about that and your experience as an interventional radiologist?
Yes, I'd be happy to. And this is great, because not only do most patients not really know what interventional radiology, I hate to say it, but most doctors also don't know what interventional radiologists do. So I'll give you a 2-minute encapsulation. So interventional radiologists are actually radiologists who read all sorts of different imaging modalities. For instance, our primary training is in radiology. So we'll read x-rays, we'll read CAT scans, ultrasounds, MRIs, nuclear medicine. Some of us even read mammo. I don't. Mammo's kind of specialized, so I don't read it. But we read pretty much all the modalities. So when you go get a CAT scan or an MRI, it could be an interventionalist that actually read your study. But beyond that, interventional radiologists have additional training that requires something called fellowship. In this fellowship, they spend an entire year or 2 years doing nothing but procedural work in which we use those same techniques of imaging, for instance, CAT scan or ultrasound, to do minimally invasive surgery. So that bridge occurs during training of interventional radiology. So then when you go out into the real world and start working as an interventional radiologist, you're using that skill of using imaging and marrying it to the skill of using your hands and putting them together to do all kinds of different procedures that can be done without surgery. And that's the beauty of interventional radiologists. You can think of interventional radiologists as a minimally invasive surgeon. On an ordinary day, an interventional radiologist could be doing an intervention upon somebody's liver for cancer, curing their cancer, for instance. We could be injecting beads into somebody's uterine arteries to help shrink their fibroids. That interventionalist does that. On another day, we could be doing a thyroid biopsy because we see so many patients with thyroid nodules. We can use the ultrasound machine to guide a fine needle directly into the spot very precisely and get an answer with no surgery, no medication, no nothing, no aftercare necessary. So those are the kinds of things that we do on an everyday basis, which thankfully, because of image guidance, it allows us to do.
That
and
is
RFA
so
is
cool.
right in that same ballpark. So we can use RFA, which is essentially similar to a biopsy. We take a very fine needle, put some local in, and put the RFA needle directly into the nodule and cause basically a thermochemical burn that causes the nodule to shrink, almost like a scar. It's really fascinating. So and that's all done through the skin, no incisions. Your thyroid remains where it is. You don't have to change anything about your medications. It doesn't cause your thyroid to stop working so that you don't become hypothyroid. I mean, that's a big deal. With surgery, you have to take medications. A young woman may have to take medications their entire life for 40 or 50 years. They don't need to do that if they're treated with RFA for these nodules. So we do all those things. So that's a very exciting field. I can't think of any other field I could possibly want to do better. I mean, that is it for me. It was the greatest thing I ever did was going interventional. Enjoy it every day.
That is so cool. I love your passion about what you do. You can always tell when doctors really love what they do. They get excited about it and they want to talk about it and tell you more about it.
And they can't stop talking. That's the problem. That's what happens.
But it's a good problem. Even to me as a layperson, that sounds very interesting. I love the fact that, like you said, it's like a minimally invasive, that's a tongue twister, isn't it? Yes. Minimally invasive surgeon, yes, where you're able to treat these problems without doing a big, massive incision and exposing this person's internal, structures and organs to potential infections. I think that sounds like where a lot of different medical procedures would be headed as we learn more about the body and imaging and different ways like RFA that we can treat problems without having to cut a person open.
That is 100% true. In fact, over the last, I'd say 15 years, my primary training before I became a radiologist, so I was a general surgeon. I was a surgeon in a heart surgery program. I was training to become a heart surgeon. But somewhere along the line, I started discovering radiology and interventional radiology, and I loved working with my hands, always loved operating. But I felt that intervention would give me a way to do things much less invasively and with much less harm to the body than actual surgery would. So I switched my residencies. I went from cardiothoracic to radiology and from radiology to interventional because I loved it so much. I had some good mentors. So, when you find someone, like you said, who has a real passion for what they do, you're drawn to them. You're like, oh, boy, I want to do what that person, because that really excites me. I found such people in my residency, and I was very fortunate. So that allowed me to get into interventional and pursue the work, like you said. And over the last 15 years, the whole field of surgery is now kind of crystallizing into what you can do with the least amount of harm. And that's where interventional sits right in the middle of that pyramid, because we've always been there doing the same exact thing. And now we're able to do even other things that surgeons used to do. We can do them now, like RFA, with almost no invasion. And same-day procedures. I mean, incredible.
So you said earlier, how many cases? You said you've done a few cases now?
Well, we did our first case in June, and we now have 3 other patients that are coming in for consultation. So we're still on the very early stage of actually doing the procedures. Having said that, I've already done RFA many hundreds of times in other body parts. So RFA is not by itself a new technique. What's new and novel about it with the thyroid is the application of the RFA energy to the thyroid gland. up until about 2 or 3 years ago, we didn't have the technology to create these type of RFA procedures for small body parts. So the RFAs that I used to do were much larger organs, such as kidneys, livers, and lungs. That's where we used it in the hospital. But as the RFA needles became smaller and smaller and the technology became much finer, we could then put those much smaller systems into the small area of the neck, for instance, where things are very close, and you have to be very careful about the surrounding structures. But if you have someone with that skill set, and now the technology comes along, it becomes very straightforward. And that's why RFA is taking off for thyroid. Both with the combination of the skill sets that are out there, not just interventionalists. As you said, there are endocrinologists who are able to do this. There are ENT surgeons who are able to do this. And I suspect there'll be other practitioners with good hands and good judgment who can do the same thing over time. So that's where RFA comes in, and that's where interventional. We've always been kind of at the middle of this junction of minimally invasive surgery, do no harm, and get the best results. We've always been there.
For patients who maybe have heard of RFA done on liver tumors or kidney tumors, maybe explain a little bit of the nuances of how you treat a thyroid nodule, being that it is so much smaller and you have to be so much more careful about those surrounding structures.
Yes, that's a very good question. So let's take, for example, someone unfortunate with a liver mass, and they have say a 4-centimeter cancer in the liver, and their options are either remove that, and with surgery, you can't remove just a nodule. With surgery of the liver, you have to do what's called a trisegmentectomy. Usually a very large portion of the liver has to be resected along with that nodule, and then the liver ostensibly grows back. But that's big surgery. So RFA is an option for some of those patients, and if they fulfill the criteria, what we would do in that case, we would put a needle, sometimes more than one needle, with many different probes into that mass in an effort to kind of thermocoagulate or heat up the elements within that nodule and cause cellular death. That cellular death eventually causes scarring, which shrinks the tumor down. So it shrinks the tumor by two ways. It shrinks it down physically, and it also kills the cells so that the tumor cells die. But the difference between thyroid RFA and RFA of the liver is very important, and that is the anatomy of the structures that surround the primary mass that you're treating is very different. In the liver, you have a lot of space. So you have liver tissue, usually around the mass. You have large blood vessels around the mass. And so when you give that heating probe element, that high-intensity heat, the heat dissipates through many channels into other organs, into the other cells that are around there. So you have a very large margin of error in the liver. In the thyroid, it's a little different because the target is smaller and the anatomy of the neck is much tighter than the anatomy of the liver. The entire neck is about the size of 1/4 of your liver in diameter. So to do the RFA requires a much more focused beam of heat, and it requires the person doing the RFA to really understand the surrounding structures. For instance, where the recurrent laryngeal nerve is. You have to know where it is. Where's the vagus nerve? Where's the sympathetic chain? Where's the internal jugular vein and the carotid artery? But people like me who work in the neck all the time, our entire life is essentially elbows into the neck. We know all these little nuances. So it allows us to be able to do exactly this in an incredibly safe and contained manner. If you can find someone like that, it's an incredible gift. RFA will revolutionize thyroid treatment, not only for benign tumors. In some parts of the world, they are already publishing results on the efficacy of RFA to ablate thyroid carcinoma. So it's coming. It's a matter of, it hasn't hit this country yet as of September 2021, but it's in the works. Give it a few years and we'll be doing the same thing, treating cancers as well as benign nodules for the same reason. It's very different. You really have to understand the anatomy, the real estate. Like people say in real estate is location, location, location. Well, this is like the real estate. The priciest real estate you can find is the neck. So really, if you understand the real estate and the anatomy, it's very safe to do, as long as you have someone who understands that.
So the consequences of making an error when you're doing RFA could be pretty significant.
Yes, luckily, like with a lot of body parts, you have a lot of margin of room. So for instance, I'll give you an example. Let's say we're doing a patient with a 20 cc nodule, which is a moderately sized nodule. And it's anterior in the neck and it produces a bulge. That's the most common cause of someone coming to me, say, for an RFA evaluation for the thyroid, is that it causes a cosmetic problem for them. A young woman with a bulging neck, who wants that, right? So they come to us. So we see it, we look at the nodule, we realize that the nodule is a little bit anterior, it's surrounded by some big structures. But with ultrasound, we can map those out. So we can actually see where the carotid artery is, where the internal jugular vein is. And because we know where the trachea is another big structure, we can pinpoint the location of the general location of the nerves that we're trying to avoid. And by having very complete control of the needle tip and visualizing the needle tip at the same time, which is what interventionalists do all day long. This is our skill set. This is why we're so suited to this particular thing. We can place that needle tip in an area visually that is away from the major body parts that we want to avoid, and while controlling the actual RFA energy, the wattage that comes out through that needle, we can control that ahead of time. And so we can make a very predictable burn. That's essentially what we're doing. We're predicting which part of the nodule will be destroyed by that heat, and only that part. So it gives us an incredible safety margin.
And the fact that you're not just putting the probe in, turning it on, and it burns an entire area, but you're moving the probe around.
Correct. It's called the moving shot technique. That's the technique invented by our colleague, Dr. Beck. I mean, I wish he was my colleague, but he's not. I've read about him. He's a man who started the RFA procedure in South Korea, and he's done hundreds by now and has a very good success rate. But so what he did was, instead of keeping the needle stationary in one position, because image-guided, especially ultrasound-guided procedures are done freehand, meaning we hold the probe in one hand and the needle or whatever object we're using to put in another hand, we can control the position of both by moving our hands. So that's freehand technique. That allows us to move the needle into different locations in real time. So exactly as you said, we give the energy just enough to cause the damage to the inside of that nodule so that we can shrink it, then we move the tip backwards. And as we move the tip backwards, it heats different parts of the nodule. And by changing the direction and depth of the needle, which we can see with the ultrasound and adjust with our left hand, we can start at a location and thermocoagulate or RFA our way back towards the top of the nodule. Eventually we can stop. And doing that, we can get 80–90% of that nodule effectively thermocoagulated. So that's how we do it. Exactly. That gives us a tremendous safety margin because we know when we put those probes in what the radius of operation of that thermocoagulation is. For instance, we'll know that the tip has a 1 centimeter working end. We'll know that the tip has a 0.5 centimeter radius on both sides and that it goes forward by 0.3 centimeters. Knowing that allows us to know exactly where the zone of operation is so we can place that needle particularly exactly where we need to be and only thermocoagulate those parts.
You know, one thing I think I want to do at some point, I haven't had time to do it yet, is create a video for patients showing someone doing wood burning with a wood burning tool where you would, you know, inscript a design into a piece of wood. Yes, it's a two-dimensional example and not exactly the same, but I think it would help a lot of patients who have trouble visualizing the concept of what's happening in RFA. So many patients they don't understand. They think it's radioactive, like radioactive iodine, rather than radiofrequency being heat. I wanted to ask you about the different frequencies that are used, higher frequencies versus lower frequencies. What's the intention behind that, and what are the applications there when you're doing
essentially, so radiofrequency basically is what it does is it moves the molecules. It basically stimulates the molecules with a certain radio frequency wave. It causes movement, and that frequency will determine how fast the molecules move and therefore how fast the molecules heat up. We use a machine that allows us to heat the elements of those cells to a certain amount. I think it's about 300 Celsius. I've got to look up exactly what the temperature, very hot, but it's a predictable amount of heat. It's not random. So we know exactly how hot those elements will be based on the frequency of that probe. Now, depending on the type of frequency that you get, the higher the frequency, the more the molecules move and the higher the heat. The lower the frequency, the lower the molecules move and the lower the heat. So depending on which body part you're using it on, for instance, let's say someone is doing thermocoagulation, and not in this country, it hasn't happened yet, but they're doing a small cancer. So for a smaller nodule, you would want to heat up much less because you don't want the surrounding spaces to heat up as much. So you'd select a probe that gives you a radius of operation that's much smaller. Whereas in a larger nodule, say a 40, 20, 30, or 40 cc nodule, you would want something that has a much higher zone of operation because we're balancing efficiency of time during the procedure and how long a patient can tolerate the procedure with how much thermocoagulation or heating we can get. Typically, our procedures will last maybe 20 minutes, at the most 25 minutes. It's not a long time. Patients are essentially lying on a table with a little pillow behind their head, and most of them can handle a 20 to 30-minute scan like that. And that's it. That's how long it takes. So in order to get that heating done within that short time frame in an effective manner, you do have to pick the correct type of needle probe to give you the kind of heat that you need.
That is very interesting. I have been doing this for 2 years now, and I've never heard that before. Thank you
Yeah.
for explaining that.
So the manufacturers, these manufacturers are very advanced because they have probably consultants like me and other people who do this all day, and they can tell them the nuances of what's needed clinically to get the best balance between efficiency and outcome. We're always weighing that. Someone could potentially do a procedure for 8 hours and have a very efficient 100% or 99% outcome, but the patient can't handle an 8-hour procedure.
Right.
Can't do that. It's not humanly possible, or it's very stressful. So we're always balancing how much we can do in the shortest amount of time to get the most amount of efficacy from our procedure. And that's how they do it. They can choose now. They give us different lengths of probe, and they also give us different, not frequencies, but really radius of operation. So the probes that they use for, say, ablating a thyroid carcinoma, a much smaller nodule, they're microscopic. The amount of work and energy they produce is very small. And it only goes out so far because it allows you that safety margin of not hitting those other structures. So that's another thing you can select up front. That helps in a great way. By the way, none of this is available 4 or 5 years ago. It just wasn't available. So you couldn't do any of this. And it's a game changer. So I'm very excited about it.
Absolutely. Game changing indeed. I know it has been for me and for so many other patients who've gone through it. We're kind of coming up on the end of this. So let's just talk one more point about how patients can find you, and since you're not on social media yet, what are your plans as far as which social platforms can we be looking for you to be joining?
Yes, so thank you for that. That's great. Our company is called Imaging Interventions, just like it sounds. So that's our website. Our website has basically our contact info. It has our phone number, our fax number, and it also has a long Q&A section for people interested in learning about what I do with thyroids, how do I do a biopsy, what does it mean, what is Bethesda classification. We put all of that is in there. Cytology of thyroid nodules. We haven't had a chance to upload my RFA information, so we're going to be uploading that. So we're so fresh in this right now in the process of doing this online that we haven't put it up yet, but it will. Within the next, I'd say 2 to 3 weeks, we'll have the RFA section up along with the video. I'm going to upload a video that's edited of our first case, which was so successful that it has to be shown. So that's going to be up there as well. And we're going to be on different social media platforms. We're going to be on Facebook, so we'll have a Facebook page, and we'll have an Instagram. I think that's very important because when we have a successful, really great case that we want to talk about, we may be able to put that on Instagram as well.
Patients love to be able to read about this on, the physician's website. They love these interviews. I get a lot of positive feedback that getting to know a doctor this way before actually having an appointment, it eases a lot of their anxiety and just the unknowns of what are they going to be like? Am I going to like them? What's their bedside manner? But also patient education is so vital. That's what patients are going to get from your social media. And of course, with your website where you're going to have your section on RFA. So I think that's a great start.
We did a large education piece prior to RFA for all the other things that we offer in the practice, exactly for that reason. A, so that people can learn from it before they even come into us, and B, because it diminishes their anxiety. It's always about diminishing anxiety. The less anxiety you have when you go for a medical appointment or a medical procedure, more likely you'll have a better outcome. Really, that's how it comes out to be. So we're always doing things to diminish patients' anxiety, and that's one of the ways is patient education. So I agree with you. You're on top of that, 100%.
I always encourage patients to be informed and educate themselves so that they can advocate for themselves the best way possible. So that's going to resonate with a lot of patients that you're on board with them. They don't want to feel like they're working against their doctor. They want to be on the same team as their doctor. So fantastic.
Thank you. And in fact, when they come in, we usually have a team of people anyway when we get there. So let's say we're doing a biopsy, we have X number of people in the room. With RFA, it's a few more. So we have a whole group of people and each person has a very specific role to be able to fulfill during that particular encounter. And I always make the patients part of the team because without the patient, we wouldn't have a team. So that is totally in line with the way we practice. That patient is at the center of a team of great people. and the patient has a role too. So we include them in the whole process, and I think they do appreciate that, and we appreciate that.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.